talked about placement and when we're going into the room to assess our patient, right? Remember we said we're going to assess the patient and we're going to assess the lungs. So when we assess the lungs and we can hear that there is sound possibly on the right side. Good morning. There's sound on the right side, but there's possibly not any sound that you're hearing on the left side. So when that happens, we want to do inspection, right? We want to inspect. When we are inspecting, what are we looking at? What can we look at to see if there might be some issue with the lung collapse or something of that nature? What might we? The shift, right? So when you go and do your assessment and you see that there's something going on that you can't hear one side of the lung over the other side of the lung, then begin to inspect and look for that mediastinal shift, okay? Look for that shift. Running late home.
Or the weather.
So how do you know the shift?
I guess if you just hear the if you don't hear the sound on one side or the other, so that means it's shifted over, I guess.
I was just saying, how do you use it?
All right.
I have a question. Can you explain the figuring out the shift thing?
Well, if you are listening to the lungs and you hear that there may be a collapse, you're thinking that the lung may have collapsed. So in the instance of a pneumothorax or something of that nature, there's going to be a push. There's going to be that one side of that body is not able to compensate for the loss that's there. There's going to be a loss in that diaphragm. So when that happens, that other lung is going to try to push over because of the pressure. And so what's going to happen is going to cause the shift in the trachea, in that area. Okay? So you see, it's kind of like you have two balloons. One balloon is deflated and the other one you continue to inflate and inflate and inflate. And as you continue to inflate it, it makes the trachea and all of that shift over to one side with that pressure. Okay?
So it's overcompensating.
Exactly. Overcompensating. A nurse, let's see. Wait a minute
I'll get
now.
it.
Come on.
I'll get it.
You know, y'all know we're not supposed to, right, we're not supposed to allow anybody in the class. We got 1 hour though, and I want to make sure that y'all get what y'all need, okay? So, what we were just talking about, and I want to make sure you get what you need, okay? We were just talking about when you're doing your assessment, and you have a patient who has an ET tube. And there could possibly be an issue with the patient's ET tube in your assessment of the lungs. And you see that when you're listening, you hear that you have good breath sounds on one side, but on the other side, you can't hear anything. So then you're going to start to inspect and look for that mediastinal shift. Okay? So that's where we stopped at. Okay. Okay, so the next thing that I want to talk about is a chest tube. That is something on our objectives that we need to know a little bit about. Remember I said that chest tubes are important to know. When you get one and take care of a patient with one, then you're going to be able to know all this stuff. When you see it and you know that there's something wrong, then you know what to do, how to fix it. So if your patient, what is the position that we want to make sure that we maintain that chest tube? Whenever that it's inserted in the patient, even if they have to be transferred, they have to go somewhere, it needs to be below chest level. We need to make sure that it is down below the patient for sure, okay?
sorry, Miss Magee.
Hey,
All right, I'm sorry.
That's
I'll
okay.
ask a quick question.
no, it's fine.
Needs to be what now?
Yeah, like a bowling.
Their head has to be done?
No, the container itself.
The container has to be like, okay.
Like, think of it
Like
like
a drain thing?
yeah, think of it like
If it was on your desk.
it has to be below.
And if you have a
Right.
certificate.
If we emailed them, it's okay?
Huh?
I
Your
emailed mine
certificate?
in. Yeah.
I'll go pull it up.
I think it was to Miss Hosley.
We told you you could.
I sent it to Miss Hosley, I think.
Okay, alrighty. Anybody else?
Because she had emailed me and asked me about it.
That's perfect. If I need something, I'll come back.
Okay, thank you.
You're welcome. Thank y'all. Thanks, Miss Magee.
You're welcome. Okay, let's go ahead and talk about, might be on the next page, medications. We talked a little bit about medications. What are some of the things that we know about taking steroids? What can steroids do to the patient?
Cause all kind of issues.
Weight gain.
What was that?
Immunocompromised?
Yes, absolutely. If a patient is immunocompromised, what is a teaching? What are we going to teach them when they get
Stay away from
home?
sick people.
Stay away from sick people.
Wash their
Hand
hands.
washing. They need to hand wash. Anytime we have a patient that has any kind of issue with infection and can be compromised, we want to discuss with them that they need to make sure that they wash their hands. Okay? So, I think we pretty much covered if there is a pneumothorax and when we're doing our assessment and what we might hear and what we might not hear. And considering and understanding that there could possibly be something that one of the lungs may be collapsed, just as we said, if someone had surgery and a lobe was missing, you're not going to hear anything, right? So definitely, if you are doing an assessment and you have a possible pneumothorax, especially with a blunt force injury or something of that nature, you're not going to hear anything on that side, okay? You're not going to hear anything on the infected side. Okay, monoclonal antibodies. Has anybody looked it up and read about it and kind of know what the teaching goes along with it? Like, what would we, if we were to administer that medication to a patient and it's a first dose? Look that up for me right quick if it's a first dose. Thank you. Absolutely. Yes, and yes, 24 hours, yes. We need to make sure we monitor that. We need to look for that. We need to teach them that they need to definitely let us know if they don't feel right. The same as we would if they were getting a blood administration. Same type of teaching,
For the
okay?
first 24 hours. That's what she said.
Monoclonal.
That makes sense? Yeah. So, we talked about whenever the nurse or the respiratory therapist or the clinician is going to come in, not necessarily the nurse, but the respiratory therapist and the clinician comes to get ABGs. So when they come to get ABGs, they are going to do a test.
Allen test.
An Allen test. That's right. They're going to do an Allen test. So there's a procedure that goes along with that Allen test, right?
Yes.
Something that you have to do.
A clue.
Exactly. So we need to understand what we need to do if the respiratory therapist comes in and does that test and why she's doing that. Okay?
What she said it was gonna be.
Include the arteries. Include. The arteries? The
They
ulnar
are.
and radial artery.
Yes, they do that, to check for
The radial and which one?
circulation.
Okay.
Yeah.
Ulnar and radial.
Okay.
You say check for radial circulation?
They check, right, you're gonna check for circulation. That's what it's gonna do. It's gonna check for circulation and, that way she'll know, how to proceed.
Yeah, each side,
And just
both
be able to
sides.
educate and talk about it and understand, just understand why they're doing the Allen test. Okay? So we talked about masks. We talked about the types of masks that patients have to have whenever they are receiving oxygen. So it would be a good idea to make sure that you know what these masks do. Okay. If the patient is prescribed a certain type of mask, we definitely want to know what each one of them does. So, okay. So the doctor came in, and the doctor says that we're going to move to cancers now. We're going to talk a little bit about cancer. Okay? And he came in and he talked to me, and he is telling me that I got cancer. So what is, when we are coming in, so we're going to come in after the doctor, and we learn about therapeutic communication. I believe you may have learned that in level 1, therapeutic communication. So we need to be able to communicate with the patient who talks to us about what's going on with them, so we understand how we need to have a dialogue. We need to understand how to dialogue with a patient who has just received a diagnosis, okay? So, if I have a diagnosis of COPD, and let's say I'm probably about 70 years old, usually I feel good. Usually I'm able to, I'm oriented, ×3, whatever. And what if something happens? What could possibly happen to me if I've been diagnosed with COPD? What could possibly be going on if my mentation changes?
Increase CO2.
Possibly. Increase CO2. So I'm going to be looking for those things. I'm going to be assessing for those things. If the doctor or if the nurse has charted that I've been oriented and then I'm not oriented. So I need to know what's going on with me, possibly, and what tests I can do in order to determine if there's an issue.
Would you do the ABGs then?
I would more than likely go ahead and do a pulse ox first. I would
And
do
see
that
what the
first. That's
O2
the
is.
least invasive. That's something that I can do as a nurse without having to have that order in order to go ahead and start my assessment. Thing about it is if we do our pulse ox, then if there's something going on, we got to do something
That
about
makes
it.
sense. Okay, gotcha.
Because and the reason why I say that is because when you work out in the field, if you decide you want to do home health, and you don't have an order to check, because usually the orders for home health, I know at this particular facility that I was working for, orders were specific. If there was not an order for you to check O2 sats, and you did it, and you found that there was something going on, then you need to address it. And then when you get back to the office, they're going to ask you, why did you do it? And I don't know, it's crazy. It's crazy. But at the same time,
So could you tell them that you could tell something was off and you were just trying to check?
Yeah, and pretty much you do that, but you will get scolded.
That's crazy.
You get scolded, and I didn't think it was the right thing to do either. But it happens, and that's how they do it. And it's because they have strict guidelines. They have payment issues that go on, and they get paid for certain things that they do when you go in the home.
If you don't have order for the pulse ox, you're not gonna get paid for it.
Say it.
If you don't have an order for the pulse ox, you're not gonna get paid for it. And any intervention you did because of it, because it's fruit of a poisonous tree, they won't pay for it either.
CMS has gotten to the point where now they just don't pay for things willy-nilly like they used to. So that's important to know. So I go all around and tell that little story just to get to, where I want you to be. Okay? So, I would say, just like if we had a chest tube or something of that nature, going back to chest tube. Put it in your area where your chest tube stuff is. Know your procedure. Know your procedure with a chest tube. Know it up and down. So if anybody asks you anything about it, you know what you need to know in order to take care of your patient. Okay? It's a good idea to assist patients. You can help them to cough. You can help them to cough and deep breathe. That's okay. It's perfectly okay. You'll see some changes in the chambers. You'll see bubbling in some points. You'll see titling in some points. It's always a good idea to understand what's going on when you see those things. If you see a change and there's not any liquid fluids coming out from the patient, if there is not any more bubbling, if you don't see the titling, all of those things, what could possibly, you need to troubleshoot. You need to understand that it could possibly be the tube has come apart from the machine. It could be that the tube has dislodged from the patient. So understand what you need to do in those instances. Okay? All right. My Scooby-Doo. Ruh-roh. All right. Okay, we talked about that. We know what to do for that. We know how to handle that. We know how to handle that too. We do. You do. We do. You do. Believe me, you know how to handle it. Oh yeah, that's a good one. That's a good one. So if I have a patient who is already having issues with breathing, what are some things that I'm not going to do?
You're not going to ask them to do any exercises.
I'm not going to ask them to do any exercises. What if they have some orders? What if they have orders? Think about their medications administration. Think about, okay, I already got this person who has a respiration problem, who can't breathe, who's short of breath. Opioids. I need to be careful. If my doctor orders opioids for my patient, I need to understand that just because I have an order for them, that I need to definitely be careful about the administration of opioids when I already have someone with a depressed respiratory system. Okay? So what are some of the things that you guys have you had an opportunity to even look at any of this since we last met?
Yes.
You have. So how do you feel about going into the test with it? I know you have 38 questions from this content.
Going in blind.
No, do you really feel like you're going in blind?
You did the
Oh.
It's gonna be okay.
yesterday?
What I was,
Who did the EAQs yesterday?
Yeah, how did y'all do on those? That was a mess.
that was
That was a mess, to be
So
honest.
constant constant bubbling, is it okay if it's gentle, or is that not good?
Gentle is fine.
Gentle's fine?
Gentle is fine,
Okay.
yeah. I mean, it's not gonna, just know
No?
know what you need to know.
No bubbling?
You need to know about the bubbling. I have the page number, I give it to you.
Yeah, go ahead.
I'll look at it in a minute. But yeah, check that. Look at the chest tube. There's a whole lot of information about it, and what you need to do on that.
And then do we need to know specifics, like with EAQs, they wanted to know specifically with pneumothorax, even though like there's a few of them that go with all of them.
Mhm.
We need to know specifically just.
Yeah, I would say look at those definitely and make sure you know the difference in where, like if it's a pneumothorax, where the cavity is. I think it shows in the
Lobe
book.
it's gonna be.
Or the
Yes,
assessed one.
right. It shows like, and then the chest tube, where if it's a hemothorax as opposed to a pneumothorax.
Okay.
Where the chest tube may be inserted. So there's some good pictures in the book that'll show you exactly what that looks like. But yeah, know the difference. Always versus pneumothorax versus hemothorax. COPD is always going to be important because it's always going to be a problem. COPD is always going to be a problem in this area. I know for sure. A lot of people have it, and remember we talked about the fact that a lot of people who have not ever smoked and may not have ever been around smokers may be diagnosed. So I would certainly want to definitely, when we talk about the thoracentesis, we talked a little bit about tests. Definitely make sure as the nurse, when you are assessing your patient, make sure you understand what you need to be looking at if there is an issue with the patient, okay? When you're assessing, that's as much as I can tell you about that without giving you an answer. Assess the patient. Make sure that you know what's going on with that patient while that procedure is being performed. Okay?
Oh, the thoracentesis.
Look for the signs and symptoms. Look for the things that may be an issue with that patient. Understand, I need to act. I need to act because this is the patient's has had a change. So if they've had a change, I need to know I need to act, okay? Always easy. Always. When we talk about positioning, right? We talk about positioning half hours. Anytime you have a patient who is having problems with breathing, we want to put them in a high phallus position. Why?
So the fluid stays, if they have fluid, it stays down here and they can breathe a little better.
And it expands the diaphragm, right?
Mhm.
So that they can expand the chest area. So the lungs will expand like they need to.
So when they're pulling fluid off, do they sit them like that too?
They usually
Kinda
they have
in
them
the triangle.
sitting, yeah, and then they need to be very, very still because the doctor doesn't want to mess up and puncture a lung.
Yeah,
So
my
those
aunt
are things
just
that
had it all
y'all need to
done.
consider
They
too.
glued her
No
lung to her
talking,
cavity.
no moving.
My aunt just had it done. I just checked her scars yesterday.
Oh Lord have mercy, she's in a lot of pain, isn't she? Yeah. And see, the thing about that is, so we need to be cautious. We need to be cautious of a pneumothorax or something of that nature when the doctor is doing those kinds of tests, because there's always risk. And when the doctor is doing an invasive procedure, one of the things that we need to make sure happens is what? Consent. Patient needs to consent. It's a invasive procedure, so we need to make sure that's done before the procedure is started, and understand that they know what's going to happen. And if we need to bring the doctor back in, so be it. Okay? Okay. So, if you are like a lot of men in my family, Don't ever want to go to the doctor. Never want to go to the doctor until something major happens.
Sometimes it's too late.
What do we need to talk to patients about? What do we need to tell them whenever there's something going on, a serious illness has happened? So say for instance, like me, I was the one that was diagnosed. I waited forever and ever and a day to go to the doctor to be seen because, I just kind of brushed things off. And then I kept brushing it off until it turned into something worse. So what do I need to do? What should I have been told when I was being educated? Say, for instance, I was a smoker. The doctor knew I was a smoker, but I didn't have any problems in the beginning. What is something that I need to educate my patient about?
That it's gonna get worse. And that your lungs will never heal. Even if you quit, you're going to stay at the level you're at.
True.
They're not going to get any better. But
And
if you keep smoking, it's just going to get worse.
It's going to get worse. So in my situation, early detection, shortness of breath, all of those things, I'll be coughing up blood, all of those things. But if I had gone to the doctor when I should have gone, when I first had my signs, maybe I could have been in a position where they would have been able to, help me. Now I'm sitting at stage 4, and the doctors, all they can do is palliative care because I let it go too long. So we need to educate when we have patients who we know are at risk. When we have at-risk patients, we need to make sure we tell them that they need to come to us and see us early if they have issues or problems.
And not sit at home with pneumonia for 3 weeks.
Don't sit at home. I had a home health patient, sat at home until she got to the point where she could not breathe at all and ended up in the hospital.
That's why my aunt had to have that done. She walked around with pneumonia for too long.
Walking, and lately people have walking pneumonia and they have no symptoms, and in older adults, they don't have the symptoms that we young people would have. So we need to be careful and discuss those things. It's our responsibility. I mean, when you think about it and we say these things and we talk about these things, we don't realize what a great responsibility we have when we start taking care of these patients, because when legal starts combing through that chart, they're going to say that what would a prudent nurse have done in this position, as opposed to what we did. And that's what they start looking at. So, yeah, I know it seems like a lot, but it is our responsibility to do those things. We need to educate the patient. Okay. Let's see. Okay. Find your chest tube stuff again. Yeah, I know, chest tubes. Chest tubes it's busy. Chest tubes, you're going to see a lot of chest tubes probably. I hope
That's
you
what
get a chance to see.
Clinical.
Yeah, I hope you do. So, when we're assessing the chambers, what could be an abnormal finding in the chambers?
Over 150 milliliters?
Absolutely. If they have like a lot of fluid coming out, and it's possibly not the color that it was maybe a couple of hours before, if it changes, like say for instance a straw color, and then it changes and it becomes bright red blood or something of that nature. So if you see those changes, those are things that you want to be alert to. And you want to, hone in on and get your doc in on that one, okay?
Yeah, anything over 55.
So understand your changes. Understand what's going on with the fluids that's coming out of the patient. It's all part of the assessment. Okay? Okay. Let's go back to your COPD person. And remember we talked about COPD patients and their diet, right?
Yeah.
We talked about what they need to eat, how they need to eat, right?
Small,
They need to have
frequent
those
meals.
small, frequent meals. And they also need to have high calories, right? They
Avoid
need to-
banana.
Exactly. See, so that we need to make sure that we educate our patient about. We talk to them about what their diet should be and how they should eat that diet.
Eat eggs, really?
That makes sense.
And then we give them, you want them to drink after they've had all their.
Well, you know what? They can have, if they don't have any fluid restrictions, and that's one of the things, a lot of times when we have that students contest as far as test questions are concerned. When we say don't limit fluids or something like that, we don't necessarily mean
So they
to
can have
tell
any at all.
them not to drink anything at all. They can drink little, small amounts during the meal. I would tell them not to drink anything, a lot of stuff, before they eat, because that's what a regular person. If you sit there and you waiting on your hamburger to come out and you sitting there sucking on your Coke, by the time your hamburger comes out, you're full.
Yeah.
So so that way we tell them, yeah, you can have sips in between, bites and things, but wait till after the meal to have that larger amount of fluid or liquid. And always with the COPD, or sometimes they'll maybe have a other diagnosis of CHF or something like that, so they may also be on some type of fluid restriction. So we want to consider that as well. And then we also want to talk to them about those nutritional protein drinks and stuff like that. Those are things that they can supplement their diet with in order to keep their weight up, because that's a big problem for them. And we talked about the diet, and we talked about when they go home, right? Remember we talked about how when they go home and how we want them to have someone that needs to assist them. So we need to make sure we do those consults, right? We need to consult our social worker so that she can set up home health if they need to have home health. If they need to have an aide to come in and help them with activities of daily living. So those are important things that we need to do as well. I think y'all are pretty well on that one. Okay. So if a patient has an order for O2, and they're going to be getting a real high dose of oxygen, the numbers are going to be up. What do we do as a nurse if we look at the O2 order and we see that they're getting a certain amount of oxygen? What should we do as far as that oxygen is concerned?
It's got to be humidified, right?
Humidify it, of course. We need to humidify it, but what's the other thing that we need to do?
Make sure it's the right mask.
Thank you. Make sure that your patient has the correct type of mask in order to deliver the amount of oxygen that the doctor has ordered. Okay? So I would say to look at your mask again, like we talked about earlier. Look at your mask and make sure you know which level of oxygen goes with which type of delivery system. Okay? Do y'all have any questions about anything? Anything that you feel unsure about? Those are the things that we are going over. I don't see anything in here that we have not talked about that y'all would need to know. Let me look at the other.
So the EAQ is hard.
So tell me about those EAQs. What question on the EAQs was an issue for you that kind of threw you off? Because I believe, if I'm not mistaken, I believe I put pneumothorax, I put a lot of that on there because I wanted you to get that exposure
Yeah, it
of
was
clinical.
just, like, pneumothorax has some of the same qualities as the other ones, and it was saying they just want specifically for that one, not the other ones also. So you had to know which ones just specifically for them and which ones are, like, with both of them.
Okay.
There's a thorax that doesn't require chest tubes, right?
And there's gonna be, yeah, I mean, in some instances, it's a possibility, I don't know, if that lung can reinflate on its own, it's a possibility, I don't think I've ever seen it where there has not been chest tubing. And there's a
One of
lung
them
that's-
is you have to walk a lot too. That's one of them.
Yeah, that's what I'm saying, so it could be something else that they can do that.
So Shay, what you're saying is you need to pick out the difference between
If it's
them,
Yeah,
the
so-
complete difference to know what they
Complete
are.
difference of
Not, none
which
of the
this one-
similarities, but the
I
difference.
did that for a reason,
Okay.
because I wanted
Because that's what
to-
you need to be able to
Thank
tell
you.
is
You
the
need to
exact
know what
difference
you're
between the
saying.
two.
Exactly.
If it's a straight pneumo, not a hematoma or hemo, you don't need,
Well, that's what I'm saying.
because you don't have any liquid to drink.
And I've never had
And it's,
where, but they can put it
and
in the,
it's tension pneumo.
see, that you're gonna
They walk
get,
around.
you're gonna get a lot of stuff like that when you get in
Because
the,
that's gonna be the walk around.
yeah, we're gonna talk about
And
that.
especially when it's secondary to Marfan syndrome.
Look at
People
that.
with Marfan syndrome. I've had patients with Marfan. Two of my medical.
And I have to go back and look at that and read up on.
If they're 6'8" or higher, they most likely have
I
Marfan.
have my EAQs right here.
Genetic
I don't know if you want to
Oh,
look
'cause
at
they're
them.
tall.
height, and they have poor circulation. Like my one medic, he lost all his toes because of that. They had prostatitis.
Tell me again, what
But
type
they-
of diet,
Ten-
tell
they
me
get
what
10,
type of
you know.
diet specifically?
I probably
For what?
High calorie, high protein, no empty fluids, right? High calorie, high protein, that's important, they need to get that protein, because they're not really, because muscle wasting can happen. They're sitting down and they're not getting up and they're not moving around,
Is that for anybody with lung issues, pretty
so
much?
they need that, they need that protein.
Aren't COPD patients real anxious and real worried and real like
Because they can't breathe.
Yeah,
They
think
can't
of course
breathe.
they are. Their O2 is fine, but they're still like, I need to go to the bathroom. I can't
Yeah,
do it."
there are a lot of them had a panicky. And like, remember we talked about those deer that headlights and they don't wanna go to sleep. A lot of times they don't sleep well because they're scared that when they go to sleep, they're not gonna wake up. Yeah,
And they sleep sitting up because it's painful to lay down to breathe.
exactly, and they can't
Physically
breathe.
painful, yeah.
So that's another thing, y'all educate them, talk to them and tell
Educate
them
that
what.
patient.
Yeah, educate that patient, that's where we are right now. We're in that mode where we're educating, we're assessing, we are looking at the patient and we're reading their actions, what's going on with them. So that's what we need to be doing when we're caring for these kinds of patients.
What all do we need to know about pneumonia?
Pneumonia?
I was just thinking.
I don't even think y'all get anything.
Because
in
we already had it,
pneumonia.
really.
Yeah, y'all.
We had it level 2.
I don't think you
So they're
get
probably
that
not gonna
in
put much on
level
that. We already got a little bit of that.
You'll get some more of vents and stuff like that. And I plan on going to a conference myself to get kind of caught up on vents and that kind of thing. So y'all will get
Acquired
that.
pneumonia.
Yeah, y'all will get that next and that stuff.
So it's like specific,
That's
just
a lot. Learning
just
how
for
to
that,
do
but
it.
like these two.
What,
then
you know,
would
the
be
thing
other
about
ones that-
being on a vent and the patient and all of that stuff, remember we talked about the respiratory therapist is your friend. The only thing that we'll really talk about when you get to 4 is gonna be knowing the numbers, knowing the readings, knowing the settings that they have them set, yeah. And so basically, when you know the settings and what they're supposed to be, then you'll know how to care for what you need to do with the patient. So it's not, we don't get too deep into that, because like I said, you always got your team there that's gonna be there working with you and helping you. So, I believe everything that I want to discuss as far as making sure that you are up on your studies. When do y'all take this test?
Next Friday.
Oh, see, so y'all got a long time
Yeah.
to have to try to keep this information. It's a long time to hit, for study. But
We're gonna be hearing other lectures on top of it.
exactly, that's what I'm saying, trying to keep this information in your head. So, very important, low carbs. Why? Yeah, we don't need low carbs. We don't need high carbs because it takes more energy to burn off those carbs. Right. So we got. So what lecture y'all got coming up?
Reproduction.
Oh, that should be easy. We all know about reproduction,
Thank you.
See, we touched on your VQ scan, but that just to kind of get you introduced to the VQ scan. So next semester, when we get into events and stuff like that, then we'll go deep on that and talk a little bit more about it. If you got a patient who has emphysema, who's been diagnosed with some type of issue, lung issue, what's another thing that you need to do when you're assessing your patient? What is something, say for instance, you didn't know they were a smoker. Get the history, but there's going to be certain signs and symptoms that you're going to see with these patients, right?
Barrel chest.
Barrel chest, clubbing nails. You're going to see those club fingers. They may have sometimes their hands are cold because of circulation. Cyanosis, cyanotic. They may have some blue, a little bit of blue around there. It's because of that lack of oxygen. And just like we said on this guy right here with the barrel chest, what happens is that the diameter of the diaphragm begins to change. And so therefore you'll see those types of symptoms. When they're breathing, you'll see them using their accessory muscles to breathe. So those are good things to look at when you're doing your assessments, and they'll help you when you're out there in your clinicals as well. So if you get a patient with all of those things going on, it's fresh in your mind, so you know what to do, you know what to look for. We talked about the glucocorticoids. You know, that issue is rush too. Sometimes I wonder if it's even worth it taking the steroids when you get all of these things that go along with it, like the rush. You get the rush, and then they have to be very careful. Let's see. Yeah, all of that stuff, just like we said, all of that in red, those things are important. Orthotesis for us this time is going to be most important. If a patient has a bronchoscopy, what would we assess? Gag Man, come on.
The bronchoscopy.
That. Oh yeah, this one. Okay. The differences, knowing the differences and what you're gonna see when you have a patient that's hypoxic, and when you get ready to check that pulse off, check the pulse of ox and see what's going on with that O2 sat. you'll probably see this, just like we said, when you have that patient that's restless sometimes, and sometimes it may be that it's just them reacting to the fact that they have the disease process going on. They get in that place where they're scared constantly, but at the same time, when you have a patient who is exhibiting these signs and symptoms, then we want to definitely check and make sure that there is not something going on. Pulse ox level less than 95%. Okay, that's what we consider hypoxic. However, keep in mind that you have a patient who's compromised. They're gonna be low. They're gonna show low. They may be in the 80s. We want to try to get them up in the 90s, somewhere around that range. We want to keep them up, but they're going to have that. So don't freak out. If you have somebody with COPD and they're below 95, maybe somewhere around in the 92s, 93s, warm up their little fingers. The little ladies who like to wear their fingernail polish. You know, we might have to do something different. Where are other places we can check your earlobe, the nose. Yeah, we can check those areas to make sure that we can get a good O2 sat on the patient. Lung cancer. I complained of that cough, but I didn't go to the doctor. I didn't do anything about it. And here I am now with an issue because I did not take care of my situation when I had an opportunity. Okay. Small cell versus non-small cell. Just like, non-small cell versus small cell. Just know what a small cell CA can do, what it does. I need to know all that staging stuff. Get that in your but sure with all the cancer. Okay. I would say definitely know what your nursing care would be, what your interventions would be, what you can do with this type of procedure. Know how to turn them. That's important. They don't want to get up and walk, but we got to do it. Because absolutely that doctor is going to write an order for you to get them up and walk. And when we get them up and walk, we definitely chart. See, that's how it works. When you have a patient and they have something going on, they have an order written, when you know what you need to know, and not saying that you're going to know everything that you need to know about a particular procedure. Remember, we talked about getting your supplies. You can go to that seasoned nurse who's there, who may know what you need to do in order to have this procedure done. Or you have your reference manuals, and you have your facilities policy where they can show you what you need to get. Once you get that stuff, it doesn't end there. When they come back to you to the floor, then it's your responsibility to make sure you do all the things that go along with what you need to, do for that patient, is what I'm saying. So when I talk about the walk thing, it's not just for giggles. It's because they want a certain effect. They want something to happen because you're getting them up and moving them around and walking. We don't want them to get atelectasis. We don't want them to get pneumonia. Let's see, psychological support is very, very important. We become case manager, we become social worker, we become psychologist, psychiatrist, all of those things wrapped up into that one title of nurse. We carry all of those hats, okay? So when we have patients who need us to be there for them, we need to be able to communicate with them. Therapeutic communication. What can we do to help them? Especially if they've gotten a diagnosis where they would be, they're going to die, end of life. We need to talk to them about it. Palliative care is important. We've had to actually, and not the doctor, the nurses, if you decide to go and work in an oncology setting, you may be the one that have to sit down with the patient and, or the family and talk to them about palliative care. It's a hard thing to do. When you do hospice out in the community, you'll have to talk to these patients and family members about palliative care and whether they want it or not. So, it's hard for us to do those things, but we get to the point of where, you know, if that's where you're gonna go, if that's where your path leads you, you'll be able to actually, you know, communicate with that patient and that family. Some family members don't want the loved one to know what's going on with them. How do you handle that? Whose wishes do you follow?
The patient.
Unless they call upstream.
Unless the patient is in a place where they're in and out, sometimes it could be a little iffy. In those instances, you may have to get the doctor involved. You may have to get a team involved, because a patient has a right to know what's going on with them. You know, that's the way I feel about it. But it could be that we need to, you know, consult other people. That's all a part of that therapeutic. When you're looking at your questions, know about that therapeutic thing when we're caring for a patient who has cancer. Okay? Let's see, we don't, yeah, that's not, that's very gruesome. NRD assessment. Did I put anything on the EAQs about flail chest? I don't think it was. I don't think I remember putting anything about a flail chest on there. But pneumothorax for sure. Hemothorax. Yeah, that's what I was talking about, that picture right there. I think we have a picture on here too that shows
The shift.
the shift, I believe it is, and then there was one on the chest tube part that shows where they actually insert. That one here shows where they're draining the blood from that lung and where it sits in the pleural space. Sometimes when they have those procedures done, it will cause adhesions too. You know, you'll begin to get those adhesions, and it makes breathing, or the work of breathing, worse. But that's it, y'all. That's all I have to say. You're welcome. I hope y'all do well on this test. I think you will.